Peach Pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BNSSG Training Hub, bringing baby, child and young person education to primary care clinicians. Today I'm joined by Clare Sheahan, who is a consultant in community paediatrics and has kindly come here today to speak to us about autism. We are going to work through a couple of cases to get us thinking about questions and issues we might face around autism in children and young people in practice. Clare's going to guide us through the autism diagnosis and support and what our role is in primary care. Thanks so much for joining us, Clare.
Thank you.
So if we start with the first case, 9-year-old Ella presents with her mum who's looking for advice. Ella has difficulties in social communication and interaction, some rigid and repetitive behaviours and sensory differences. She was assessed by the Specialist Autism Assessment Service 18 months ago, but did not meet the threshold for an autism diagnosis due to some strengths. She had relatively good non-verbal communication skills, a group of friends who she relates well to, and that she's able to relate to others better when calm. Ella has, however, a few significant areas of need. School non-attendance, both absconding and refusing to go to school, worried about leaving her mother and anxious about schoolwork. Not reaching her academic potential due to low attendance, despite good academic abilities. Frequent meltdowns with emotional dysregulation and difficulty managing her feelings since a young age, often with seemingly small triggers. Controlling behaviours, and high levels of anxiety and stress when Ella becomes quiet and avoidant of eye contact. Ella is otherwise a healthy 9-year-old with normal term birth, pre- and postnatal periods, normal development apart from slow to develop speech, which improved at nursery, and difficult to manage tantrums age 2. Ella has an EHCP, an Educational Health and Care Plan, at school with one-to-one support, but her level of need means that school are unsure she'll be able to stay there. Her family are finding it difficult to manage her behaviours. Mum wonders if a private autism assessment might help to get her a label of autism and unlock additional support. Mum's frustrated by disagreements around support with school, so is hoping her primary care clinician can help. Clare, can we start with the basics? What is autism?
That's a very good question. Autism is a name that we have given to a neurodevelopmental condition. I'm reluctant to use the word disorder. There's quite a lot of controversy about using the word disorder. It is a pattern of neural development which results in neurodivergence. So a person is out of a typical scale of what we would expect in a number of behaviours. And the main areas are social communication and interaction and repetitive and rigid behaviours.
Thanks. Could you help us a bit with the nomenclature as well? Do we say autism or autistic spectrum disorder? I mean, you already mentioned that disorder can be a thing to avoid. And is it a child with autism or an autistic child? I'm sure every child and family has their preference, but what should we use as our starting point?
It is a little bit of a can of worms. There has been quite a lot of work which has been done on this recently to try and get a good starting point. The first thing is, as I've already said, that the word disorder is not liked very much, and so autism is often preferred. The other thing is people prefer to be called autistic rather than a person with autism. They feel that autism is integral to who they are, so it isn't an added thing which is slapped on top of them. Autism is a spectrum condition rather than a little bit autistic, and a little bit autistic is really not liked. There's also then a divide as to whether autism is a disability or not. But autism is a disability condition, and so from legal terms, there can be an importance around that.
Fantastic. And you mentioned a little bit about what autism is, how it's diagnosed.
Yeah.
What sort of features should we be looking for?
We look at the DSM-5 to make an official medical diagnosis. One of the difficulties about it is that it tends to be very deficit orientated. As medics, we look for deficits. So there can be some problems with it, but it is what we use to make an autism diagnosis. As I've said already, we look at social interaction and we look at rigid and repetitive behaviours. For a diagnosis, you actually need to have 3 areas of social and interaction difference and also at least 2 areas of rigid and repetitive behaviours. For the social communication and interaction, we're looking at reciprocity. Do we have a sort of give and take in conversation? I say something, you say something, I say something. Not like this monologue I'm giving at the moment. The second part is non-verbal communication, and it's how that non-verbal communication is used. And the third part is around friendships and interaction, and you need to have all three parts of that. The other part is the rigid and repetitive behaviours. First aspect is repetitive behaviours, so they could be motor behaviours, echolalia, so repeated speech, or just patterns of play. The second is rigid behaviours or difficulties in coping with change. The third aspect is often about preoccupations, very, very intense interests. And the fourth is sensory differences. And you need to have at least two areas that are functionally impacting you.
And I think that's really key there, isn't it? The functional aspect of it. A lot of parents come to us and they see these traits, but actually there isn't that functional impairment going alongside it.
Absolutely. And actually that is within the DSM-5 that it's got to be functional impairment. So the first thing is if someone is having some difficulties, put into place interventions and adjustments, and it's not, I need to just check because I would like to know. We're not going to be assessing anyone who hasn't got convincing functional difficulties.
Okay. Ella sounds like she does have a number of autistic characteristics. She's also got some strengths. Do strengths prevent a diagnosis?
They don't prevent a diagnosis. All people with autism do have strengths, and that's actually part of it. I often would talk to a parent and a child when I'm first giving a diagnosis or exploring a diagnosis that an autistic brain is a brain which has developed in a particular way, and that gives strengths as well as difficulties. Strengths can include things like good memory or good pattern recognition, often good systemizers, very organised about information and will prefer situations which are predictable with good routines. And that's a fantastic thing and can give real advantages to life. So strengths are definitely always there. She had strengths in her non-verbal communication, and what was interesting about her non-verbal communication was it was very variable. And in order to get a diagnosis, you need to have those difficulties going across contexts. It was noted that her variability was very much in line with whether she was emotionally dysregulated or not. So she absolutely has very, very high levels of needs. When you look at what she's presenting with, she isn't presenting with autistic difficulties. Her difficulties are school non-attendance, which could well be emotionally based. She's not reaching her academic potential and her attendance is very low. So it's really understanding what's leading to that. And again, she's got frequent emotional meltdowns and emotional dysregulation. You can have emotional dysregulation as part of autism. However, there are lots of other reasons why you can be emotionally dysregulated. She has controlling behaviours and also high anxiety and stress. It's really interesting when you look at those factors to think, is there another thing in Ella's life or something else about Ella that may be contributing and not just putting everything down to autism?
So when you say there are other things that could lead to those frequent meltdowns, what sorts of things are you thinking?
Well, I can talk about Ella in particular. When we actually delve into her social background, there's a lot more going on than was immediately apparent. At 7 weeks of age, the police were actually called to her house because of domestic violence. Then she was in and out of social care episodes, being on a child protection plan for the first 4 years of life because of ongoing domestic violence. Children who in their early years experience trauma, actually their brains develop differently. And a lot of the problems that Ella is coming with actually have more of an attachment difference or trauma-based theme to them. And that may actually need a different approach. There may well be some autistic strategies which would be very helpful for her, but it may be that there are other things as well which are needed for support.
Okay. Can we also address Mum's question about unlocking additional support? Is it true that you need a diagnosis of autism to unlock support? Can you talk us through what might be available with and without a diagnosis?
This is a really confusing area because a lot of people will be told by a wide range of professionals that they need the diagnosis in order to get support at school, to get disability living allowance and lots of other things. The reality is you do not need a diagnosis to get additional support at school. Additional support is based on needs and it's not on diagnosis. And I do know a number of people who have been given an autism diagnosis who have not been accepted for educational healthcare plans. And I also know children who have not been assessed or have a diagnosis, but because of the high levels of need and their needs which have autism overlap, have got educational healthcare plans. And again, disability living allowance is meant to be done on need. I think some people do find that their experience is that it may be easier, but actually if you can get things written well, actually putting the needs forwards, then you don't.
Thank you. Mum also mentioned that she was wondering about a private assessment. What's the role of the private sector in neurodiversity diagnoses?
I think it's growing, and there are some good quality private providers. There is guidance on the website for the Specialist Autism Service in Bristol, North Somerset and South Gloucestershire, which gives some guidance of what to look for a good quality private provider. The other area that's opening up is Right to Choose. Not quite sure how that's going to play out because I'm not sure whether there's going to be enough providers who are recommended through Right to Choose to actually cope with the demand. So it will be interesting to see how that works through.
And are those diagnoses just as reputable if they've come from a private provider?
As long as the provider is using nice guidance, they are reputable. Specialist service will not repeat an autism assessment if a child has been given an autism diagnosis privately. There'd probably be a lot of damage done actually if they were reassessed and a diagnosis was removed. The support should be around the needs of that child, and so that's what we should be focusing on.
Thanks, that's really helpful. So how would you want the primary care clinician to approach Ella? What would you want them to do or advise?
To listen to the family. This is what the mother is needing, is to actually find out really what she's wanting out of an autism assessment. What is really the problem? Because it feels as though she's a person who just doesn't know what to do next. And she's decided that another autism assessment is needed, but it probably isn't the right answer for Ella. Have there been any big changes in the last 18 months which actually shift the situation? And have the recommendations from the assessment that was done 18 months ago actually been put into place? Is it worth revisiting that report and looking at those recommendations and seeing if there's areas that could be looked at again? An assessment isn't just about giving the diagnosis. There's an action plan which has got lots of signposting around it. The next thing is it would be worth looking for the report from Ella's autism assessment to see whether there were actually some good reasons behind why she didn't get the diagnosis. That just may help guide. Probably be more damaging to go down that line and then meet with the same outcome again.
It's also time wasting really, isn't it? Focusing in the wrong area if that's not where the need is coming from.
Absolutely. Then underlining that the autism diagnosis doesn't necessarily unlock lots of resources, because actually that's what mum's coming for. She may well be quite disappointed with the result. So not only will she wait a very long time to get a diagnosis or not a diagnosis, but it may not make very much difference. Signposting to resources. There is work being done on the web pages at the moment, which should mean that in the next few months, there will be much more easy to follow information for families. That will be advertised when that's gone live. So hopefully that will help hold people a little bit more. The other things, I suppose, is looking, is there anything that can be done now? And it may be that a further CAMHS referral, more around that emotional-based aspect, if she's meeting their referral guidance, or if the family are really not coping, social care.
And ideally, you'd want the referrals to come from school rather than primary care. When do you see primary care clinicians sending direct referrals?
If a child is not on a school roll, that's not just children who are not at school, so many are still on a school roll, so home educated children. They don't have their SENCO to support them in doing a referral, so there will be a small group of children where that's the case. Children who are early years, they haven't quite got to nursery. And actually, those are quite a different group. They've often got different development. And so I think that the GPs may well be more involved in those children anyway. And GPs may also be involved if families are wanting the right to choose option.
Thinking about those early years, it can be quite hard to pick out those autistic features because some of those behaviours can be typical at that age. How young can you diagnose autism?
You can actually diagnose autism quite young. With the specialist service, we don't accept referrals until the age of 2 years and 4 months. But if you've got a child who there is a wide range of developmental delays, they can be referred to the community paediatricians at an earlier stage for assessment around their development. And actually, the community paediatric service and the autism service work hand in hand, and children do flow from one to the other. All the early year children who are referred to the autism service are seen by community paediatricians.
That's really good to understand. Thank you. Moving on to our second case, Mum presents with 11-year-old Tom, who had a diagnosis of autism in Gloucester. She'd like to be linked up with the services locally and wonders if she needs re-referral to the local specialist autism assessment service. Tom's family were aware of developmental difficulties from a young age. His speech was initially delayed, but started talking in full sentences by 3 years. He's very avoidant of eye contact. Tom had a previous intense interest in trains and continues to be interested in modes of transport. He's academically doing well in mainstream school and is particularly good at maths. The plan is to stay in his current school until secondary school starts next year. Tom has 2 friends who he's known since preschool. They have some similar interest and he enjoys watching planes taking off at the airport together. If they're not around, he'll play alone. He's very literal and can get upset if others are not keeping to the rules. There are times where things have gone wrong in friendships and he doesn't understand why. Tom's had adjustment around school uniform as he doesn't like the material of the polo shirt. He's anxious when there are unexpected changes, and that can make his behaviour difficult to manage. The family have already put in place good systems to support him before his diagnosis. At school, he's accessing social skills groups, and the teacher checks in with him every morning with clear plans. There are good plans around his transition to secondary school next year. So Claire, what are your initial thoughts around this case? And how would you want the primary care clinician to respond?
Tom sounds lovely, and it sounds like he's got a great family around him who have worked really hard with him to manage the areas of difficulty, but also to help him with the areas of strength and things he's good at. So he's actually living a very full life. I think he's actually quite a success story of a child who's being very well held by the family and also school. But despite that, there are still challenges. The first thing I'd look at is his age. He's 11. That's actually an area of change. And it may well be that we're getting to a stage that he's got a few more hormones. He's changing a little bit. He may actually need to be a bit more part of what's going on and get a different understanding of autism as part of who he is. If he can understand that, that's really good for him going forwards, keeping up his self-esteem, his self-confidence, making him feel that he's made exactly right. Those are all really good things for him. So I think we've got a mother who has come to the GP because she's really wanting to make sure that she's doing everything she can for him. She's not necessarily seeking anything in particular. She's just wanting to make sure that there isn't a stone which needs turning. The reality is the autism service doesn't offer ongoing support for children once they've got a diagnosis, even though he's moved area. We do recommend there's signposting to our website because that actually gives lots of information of the local resource that can be tapped into. And I'd particularly suggest going to the local offer. He's moved into Bristol. The Bristol local offer gives the information of what the Bristol Council have available for families and children with special educational needs. And that includes outings, events, as well as support.
And is that Flora?
Flora is the number you go through for Bristol, but there's an equivalent in South Gloucestershire and also in North Somerset. All councils have a local offer.
Brilliant. So that's some good lines of support that you can recommend him there. Are there any other supports locally that you would want to signpost mum to?
There's various parent-led support. Bristol Autism Support gives courses. On the local offer, there's information about courses, and it may well be that the family have done courses around autism when he was younger. But as you can imagine, as a child grows older, the sort of information that families are looking for is very different. There's something called Teenage Life, which offers courses for children. Although it says teenagers, it's really children from the age of 9 years up to 18 or 19, divided into a younger group and an older group.
Brilliant. Thanks very much. Mum mentioned that they were aware of differences with Tom compared to his siblings from a young age. Do you think that all children who fit the diagnosis of autism should be referred, or only those with a significant level of unmet needs?
It would be lovely to sit down with every family who's got a concern and talk through it. The specialist services are not able to do that because there are just too many wanting that type of services. And so it means actually the threshold to get into the services is much higher, and you do actually need to have significant functional impact in order to be accepted.
Is that functional impact that's not being met? Because he obviously has some functional impacts, but those needs are being met really well.
Absolutely. So it's functional impact despite adequate intervention and support. Tom does have some areas which are a bit challenging. All children have some areas which are challenging, and it's a case of trying to make sure that everything's being done which can be done. And sometimes children just need to go through a difficult patch and they come out as long as they're held reasonably well, and taking a step back from it can be quite helpful.
Could you also tell us a little bit about the ICB's transformation project?
There is an increasing focus on neurodiversity needs. This has been formed with all the stakeholders as a response to the really difficult situation we've got around capacity and demand and increased waiting lists. The whole idea is to help neurodiversity needs understood at a very early stage and have interventions and support put into place. Portsmouth have a big research project around Portsmouth's model of neurodiversity needs, where the assessors are actually within education. Children have a neurodiversity profile which is made within the educational setting with the family, and then a plan is made on how to meet those neurodiversity needs. After that, they actually have to go through 2 cycles of support. So it's reviewed, looked at again, plan is made to change. So the child is actually getting real support before there's even the thought of referring for an autism assessment. The initial findings from Portsmouth seem very, very encouraging, and there's areas all around the country that are looking at similar sorts of models.
That sounds absolutely fantastic. Has that started in BNSSG, or is that something they're looking at for the future?
There's a pilot project. We've already got schools signed up for it, and I think it's starting September, October this year to see how that works. They're going to be supported by the Autism Diagnostic Service, but actually it's going to be the schools that are going to be running the assessments. There's huge buy-in. There's a lot of amazing educational needs coordinators in schools who are just really crying out for help. And they don't necessarily believe that a diagnostic assessment is all that's needed. They're already working really hard with plans around children, and actually having something which is a little bit more focused has been very, very welcomed by them.
That sounds like an absolutely fantastic project. Can we think a little bit about what the advantage of a diagnosis is? So you've already talked about Tom understanding himself better, but also the fact that the diagnosis doesn't unlock support. When we're having those conversations with parents wanting a diagnosis, what are the advantages of that?
The advantages are very much around identity and understanding. It can mean that you can be part of a wider group. So if you have an autism diagnosis, people can reach into other groups with other people who've got an autism diagnosis, and there may be some shared understandings. By recognising neurodivergence, which doesn't necessarily have an autism label attached, you can often still access some of those support measures. There are definitely families who prefer a neurodivergence model rather than an autism disorder type of model. There's more of an emphasis on recognising the strengths and growing the strengths. It's not all about the deficits. There is variability in what people are actually seeking. When you've got a name like autism, it sort of puts things into a box that package it, and people find that easier to share with their relatives, to say, well, he's autistic. Although there shouldn't be, and we're trying to move away from autism having services, there are still a few academy schools which require a diagnosis. The council schools in Bristol do not, even if there's special educational needs provisions, but there are some that are requesting one. I'm hoping that will move because I think there's an inequity around that. Understanding yourself is very much one of the central things. But also when you go into the adult services, there may be benefits when you transition to adults from childhood.
Okay. How long can children and young people expect to wait for a diagnosis?
At the moment, it will depend a little bit on which priority group you're in. Children who are in what we call a priority 2 group, which basically means that they may be having difficulties around accessing school, significant family breakdown, or they're on child protection plans, quite high level differences. Even those children are waiting over 2 years for an assessment. If you have a child whose parent would like them to go to a particular educational place, which is still saying that they need autism, there will not be a rapid response. There are very few children where they are being seen very quickly, and those tend to be children maybe who are being adopted or who have got really high level needs. Often with complexity, which may mean that autism isn't actually the reason behind their behaviours and their presentations, but it's really confusing the whole picture. We're probably only seeing 2 or 3 a month at that high level.
Okay, so they are quite extreme cases.
They're really extreme cases. And so the ones which actually seem quite extreme, but they're not reaching that very top tier, still a couple of years wait. And then if you're not reaching that group, we're talking of years, really.
So families really do need to be aware of that, don't they, and not wait for that before we start looking to address those needs, but actually having that needs-based approach.
Absolutely.
Whilst they're waiting the assessment.
So at the moment we're doing a real shift to try and think about needs and putting interventions in before referral in. And actually I think this is by far the best thing for the child and the family anyway. We've been doing a harm review looking at our waiting lists and actually trying to understand what harm comes about because of being on a waiting list. The biggest theme is that people are withholding, looking into getting support around their needs. Before I find out, I didn't really want to do anything about it. So that's a narrative that you get quite often. And actually the people who do far better, you see such a difference where intervention's been put into place beforehand.
And what about through right to choose? Does that bring the waiting time down significantly for the patients who choose that?
It's too early to tell. We've just got to watch this space. In order to provide enough capacity to make a significant impact on the waiting list, you would need to have enormous amounts of assessments through right to choose. I'm not sure how possible that's going to be.
And it does feel like the rates of autism are increasing and the waiting times are getting longer. Is that reflected in what you see?
We're definitely having more people referred. There have been some studies that have been looking at this. There was a UK cohort study which looked at the number of diagnoses that were given between 1998 and 2018, and they went up by 787%.
Wow, gosh, okay.
So there's enormous amounts more diagnoses. And so you can think, right, is that because it's becoming more common? So it was quite useful that I found another article, which was a Swedish study, which looked at the autism phenotype and whether there'd been a shift for a 10-year period. This was in 2015, and they weren't finding an increase in autism phenotype in the population that was being studied. It's being recognised more. And if you go back to the first study, the groups that there was the biggest difference in were over 19s and in girls. That is just sort of showing maybe there's a different group that wasn't being recognised before, and it is now, and that's a major part of the increase.
And do you think that's because girls are known to typically compensate? Maybe we're just better at recognising that now, or is there logic that you can see there on those being the particular groups that are increasing?
For girls, I think, present with mental health difficulties, they're often more socially able when they're younger. The word masking is used quite a lot. I think we've got to be a bit careful of the word masking. Everyone masks to a certain degree. We all alter the way we are. If you're autistic and you're masking all the time, that can be very, very tiring. It's not so much the masking's the problem. It's the doing it without it being realised that's what you're doing and giving recovery time.
Interesting. Thank you. Is there anything that we can do, particularly in primary care, to support?
First, having an understanding of who to refer in and who not, and also actually to know that school are probably the better place to do the referrals than GP. So actually stepping away rather than stepping towards it is a good starting point. If you've got a family who is seeking a diagnosis, Find out, why are they wanting that diagnosis? What is the motivation for that? And what difference do they think that diagnosis is going to make to them? Make sure there's an understanding that there is such a long wait. They will wait years before an assessment takes place, and that it's really, really important not to just sit and wait for it, but to be proactive in seeking support and actually putting things into place first of all. It may be that signposting to Right to Choose will be appropriate. It's also recognising that sometimes the children with the most challenging presentations may not meet the criteria for autism. And that isn't saying that needs not being recognised. A lot of people have so over-focused on autism, and so it's just maybe helping families recognise that autism is not the only thing that causes a problem.
Thank you. So I think for me, from our conversation today, the key take-home messages are to have that needs-focused, not diagnosis-focused approach, and that the vast majority of support, including EHCPs, don't actually require a diagnosis. The importance, as you said, of seeking support whilst you're awaiting the assessment and not approaching that as your next step. Considering the social causes as well, rather than just putting it down to a neurodiversity diagnosis if somebody already has one. And recognising strengths. That was really interesting hearing you talking about that. Thank you. We've discussed quite a few resources already today. Are there any other ones that haven't come up in conversation that you wanted to highlight?
I think it's worth being aware of the National Autistic Association website. You can get lots of useful information there. There is one that's particularly good for girls who are neurodivergent. You don't actually need a diagnosis of autism for this, and it's Neon Daisy. A lot of people find that a really helpful organisation. Bristol Autism Support, I think I've already mentioned, but there's also the parent carer organisations, and there's one in North Somerset, South Gloss and Bristol. If you go into any of those, you'll probably then find additional resources. And as I say, the Sorona website is being redone at the moment. There's a lot of really helpful information. It's just sometimes a bit difficult to negotiate.
Fantastic, thank you. And if you go on the Child and Young Person Education page on the Training Hub website, there is actually now a new section at the bottom called CYP Accurix templates, and there is one for autism. So if anybody hasn't got one set up already at their surgery, then it's worth just opening that up. It's as simple as copy and paste, and then everyone in your practice has got quite a number of those resources that we've talked about today that they can send at the click of a finger. Perfect. Thank you very much for that. Thanks for joining us. Do give feedback and join us next month when we'll be talking about learning disabilities. The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen and interviewees are not liable for any clinical decisions made as a result of this podcast.